Now we'll talk about the systemic therapy of psoriasis. There are a large number of systemic drugs available to treat psoriasis. The advantage of treating psoriasis with systemic drugs is it is not messy and not unpleasant like the topical therapy, and it is only used in moderate to severe type of psoriasis. But otherwise, if the disease is mild, then we only use topical therapies. The systemic drugs available are Methotrexate, Retinoids, Cyclosporine, and certain other biological drugs which are now being introduced in the market. So these are the newer drugs available. Methotrexate was successfully used in skin diseases since 1951. It's used in skin diseases. It was found to be effective in treating psoriasis by firstly it was used by Edmondson and Guy, who used it in psoriasis in 1958. FDA approval for use was given in 1971. From then, use of methotrexate in psoriasis started. Methotrexate, it's basically a synthetic analog of folic acid. It's just like folic acid. The mechanism of action is it will inhibit the DNA synthesis, mostly by inhibiting the enzyme called as dihydrofolate reductase. So this dihydrofolate reductase enzyme is inhibited by methotrexate. So it has an anti-metabolite effect. It stops the mitosis in the hyperproliferative epidermis. So in psoriasis, there is increased proliferation of the epidermis. To decrease the proliferation, to stop that process, the methotrexate will inhibit the enzyme called as dihydrofolate reductase enzyme. Here you can see methotrexate is irreversibly inhibiting dihydrofolate reductase, and partially reversibly it will inhibit thymidylate synthetase. So since this enzyme is inhibited, folic acid won't be converted to tetrahydrofolate. So later the formation of DNA is affected. Even by inhibiting thymidylate synthetase, we see that DNA formation is not happening. So therefore there is no cell proliferation happening in methotrexate therapy. So here is a methotrexate acting and inhibiting the enzyme called as dihydrofolate reductase, so no tetrahydrofolate is formed. If there is supposed to be methotrexate toxicity, then we give another compound called as folinic acid or leucovorin, which will replenish the tetrahydrofolate, and then that will help in overcoming methotrexate toxicity. Not only dihydrofolate reductase, methotrexate also inhibits other enzymes called as ICAT, which is 5-amino-imidazole carboxamide ribonucleotide transformylase. So this enzyme also is inhibited. When this enzyme is inhibited, there will be increased intracellular adenosine. Adenosine is said to have an anti-inflammatory effect. So this increased adenosine concentration will help in anti-inflammatory action, and thereby inhibiting ICAT also is helpful. Another mechanism by which it acts is by inhibiting the polymorphonuclear function and decreasing secretion of cytokines like TNF-alpha, interleukin 6 and 8. So therefore again it has got an anti-inflammatory action here. So the inflammation in psoriasis is reduced. Also it modulates the action of ICAM1, which is an intercellular adhesion molecule 1. So this action is reduced. So therefore all of which together will help in its anti-inflammatory action. The uses in psoriasis, it is only used in erythrodermic psoriasis when there is more than 90% of the body surface area involvement with erythema and scaling present. Only then we can use methotrexate. Okay, so then can we use methotrexate. And in psoriatic arthritis, which is not responding to conventional therapy, you have given conventional therapy but it's not responding, only then you give this. Then in pustular psoriasis, which is generalized to debilitating the patient, then you use this. And psoriasis which is adversely affecting the employment of the patient, then you use methotrexate. And in severe plaque psoriasis, which is occupying more than 20% of the body surface area, which is not responsive to conventional therapy, then you go for methotrexate. Then if there's lack of response for phototherapy or systemic retinoids, then you treat it with methotrexate. So these are the uses or indications of methotrexate use in psoriasis. The FDA approved indications of methotrexate are psoriasis and Sézary syndrome. It is a type of mycosis fungoides, a severe form, which is a cutaneous malignancy. In that you can use. Other off-label indications are pityriasis rubra pilaris, pleva, Retter's syndrome, immunobullous disorders like pemphigus vulgaris, bullous pemphigoid, cicatricial pemphigoid, autoimmune connective tissue disorders like dermatomyositis, LE, SLE, scleroderma, morphia, you can use it. Vasculitis like leukocytoclastic vasculitis, Behçet's disease, Kawasaki disease, atopic dermatitis, sarcoidosis, keloids, mycosis fungoides, prurigo, alopecia areata. These are the other miscellaneous conditions where methotrexate can be used. But FDA approved is psoriasis and you have Sézary syndrome. So these are the two conditions where methotrexate can be used, which is FDA approved as well. Contraindications where you should not use methotrexate: it should not be used if there is severe anemia, leukopenia, and thrombocytopenia present. If the counts are less, If there's pancytopenia, you can't use it because again significantly it will reduce all the counts because it will cause myelosuppression. It is metabolized in the liver, so it can't be used in liver function abnormalities because then there'll be increased methotrexate toxicity. Or in hepatitis patients, cirrhosis, fibrosis, and all, you can't use this. Even methotrexate also has a side effect of hepatotoxicity, so it will be increased again. So you should not use it in that condition. Impaired kidney function, concomitant medications which increase methotrexate levels if the patient is taking, like trimethoprim, sulfamethoxazole. If the pulmonary function of the patient is reduced, if the patient is pregnant or lactating, children, we don't have studies to tell that. Then if the patient has currently, if the patient is planning to get pregnant, then you should not use it because it's a abortifacient and a teratogenic drug. Also, it has effect on the sperms, causing oligospermia. You should not use it in men and women both if they're planning to have children. Then in severe infections or acute active infections, peptic ulcer disease, hypersensitivity to methotrexate, unreliable patient, pleural effusion, concomitant hepatotoxic medications, immunodeficiency syndromes, concomitant radiation therapy. So these are the conditions wherein you think twice before you give methotrexate to the patient. Or so some of them are absolute contraindications, some of them are relative contraindications. By weighing both of them, you can start methotrexate. Baseline investigations before starting methotrexate would be you have to take a careful history of the patient with physical examination, identify any risk factors if it is present for toxicity in the patient, be it drugs, infections, or any other systemic manifestation. Recording whatever other medication that the patient is taking is important. Baseline, we have to do complete blood count, platelet count, liver function test, serological testing for hepatitis B, C, renal function test, HIV testing has to be done. And when it comes to liver biopsy, it is said to be the gold standard to see if the patient has fibrosis or cirrhosis of the liver. It is a gold standard test, but it is associated with its own complications of the procedure. So there can be grave consequences of the procedure itself of liver biopsy. So we don't usually resort to liver biopsy as the initial investigation. We first evaluate it using non-invasive techniques. You can do MRI, you can do ultrasonography. There is another study called as serum levels of this peptide called as procollagen type 3. So there are other modalities to finding whether the patient is prone for cirrhosis or if the patient is really having cirrhosis or no. So if you go for that initially and then come for liver biopsy. And also when the patient is on methotrexate, if the patient has no comorbidities, like he's not diabetic, hypertensive, no liver disease, no family history of liver disease, no history of any cancer, if everything is all right, you can go for liver biopsy or any liver related investigations you can do apart from LFT. Higher level of investigations you can do it if the patient has crossed a cumulative dose of 3.5 to 4 grams. After the patient crosses a cumulative dose of 3.5 to 4 grams, you can plan for liver biopsy. But if the patient is having comorbidities, like if the patient has liver disease or hepatitis or family history he has of liver disease, then cumulative dose would be 1.5 grams. So after this amount, you can go for liver testing. Before starting methotrexate, we have to give test dose. Test dose would be of 2.5 to 5 mg of test dose. A single dose is basically given, and then we have to evaluate for CBC and other investigations. LFT, RFT needs to be done after 7 days. If everything is all right, then you start a weekly dose of 7.5 to 15 mg per week can be started. This is the weekly dose which can be continued to giving. But the per kg dose is 0.2 to 0.4 mg per kg per week. So this is the per kg dose. But the 7.5 to 15 mg is the per week dose, not per kg body weight dose. Okay, and we follow this Weinstein-Frost triple dosing regimen. That is, we divide the weekly dose into 3 doses and we give it at an interval of 12 hours. So today morning he'll take at 8 a.m., then at 8 p.m. he'll take, and next day morning at 8 a.m. he'll take. So that's how we divide the doses and give to reduce the nausea, vomiting, and GI side effects. Also, we give this. Okay. That is called as Weinstein-Frost triple dosing regimen. Injectable, not only oral methotrexate, even injectables are available. You have subcutaneous, intramuscular, intravenous. If the GI side effects are present, you can go for the parenteral method. Liver biopsy, if cumulative dose is, as I told you before, this is about the cumulative dose. And the liver biopsy has to be done 2 days after the last methotrexate dose is taken. The blood investigations has to be done 1 week after the last methotrexate dose, so that you don't get false positive or false negative results. Response to therapy is seen within 7 to 2 hours. You see that response starts, and most of the lesions will clear in 8 to 12 weeks. So, within 3 months, you see that there is clearance of lesions of psoriasis here, and the patients are adequately controlled on 7.5 to 15 mg per week dose is enough. Maximum per week dose would be 30 mg. 30 mg per week would be the maximum dose that you reach. You can't go more than that. The aim after starting methotrexate, the aim is to get control of the disease. You don't completely cure the disease. You don't aim for complete cure of the disease. You just have to control the disease. And then maintenance therapy, you can start with other treatments available which are less toxic. With topical therapy, you can maintain the patient. Withdrawal also has to be tapered, and it should not be suddenly stopped. It has to be tapered every 2 weeks. Side effects would be you have nausea, vomiting, abdominal pain, fatigue, headache, loss of libido, impaired memory, then leukopenia, thrombocytopenia, anemia. These are the hematologic complications which are very important to evaluate weekly and monthly whenever concerned if the patient is started on methotrexate. Then mucocutaneous side effects like oral ulcerations, erosions, delayed phototoxicity, tenderness, necrosis over the plaques, then rarely urticaria, angioedema, vasculitis can be present. Hepatitis and cirrhosis are the liver complications. Then pulmonary complications include interstitial pneumonitis. Fetal developmental defects can be there if the patient is pregnant and taking methotrexate, like cranial defects and absence of digits, which is phacomelia, can be seen. Carcinogenesis, that is in rheumatoid arthritis, they'll use high dose of methotrexate. Only then it can lead to carcinomas like lymphomas and SCC. Idiosyncratic reactions can be seen, and then opportunistic infections can be increased here. There's this entity called as methotrexate osteopathy, which has a triad of there is bone pain, there is osteoporosis, and then there is compression fractures. So this is the methotrexate osteopathy, which is seen with methotrexate. These are the additional complications. Ventricular cardiac arrhythmias, lowered seizure threshold is seen. You should be careful when you start methotrexate. Hepatotoxicity again is a very important side effect here. Increased risk of cirrhosis and fibrosis is seen due to accumulation of the polyglutamate forms in the hepatic cells. That is why hepatic cirrhosis is seen. Additional risk factors if the patient is alcoholic, liver disease, diabetes mellitus, obesity, hepatitis B and C infections. If it is associated, there's increased morbidity again. Weekly dosing has lower risk here. It is said that the dosing that we use for psoriasis in India does not really cause any much trouble to the patient. Other non-invasive investigations that you can do are liver function test, MRI, radionuclide scanning, ultrasonography. Then we have ultrasonography, dynamic hepatic scintigraphy, transient elastography, serum levels of amino terminal propeptide of type 3 collagen. This was what I was telling you about. This is one of the serum tests which can be done to know if the patient has cirrhosis. And then there's this grading of liver biopsy which shows the histologic findings. We have grade 1, 2, 3A, 3B and 4. Grade 1 is mild fatty infiltration, grade 2 is moderate to severe fatty infiltration, grade 3 is mild fibrosis, grade 3B is moderate to severe fibrosis, grade 4 is cirrhosis. So you have to, if the patient has reached this position, you have to stop methotrexate. You can't continue giving methotrexate. Here, if there's mild this thing, you can continue giving methotrexate, but here you have to monitor the patient and give methotrexate. You can't continue just like that. Contraception is an again important thing to be practiced here. For males and females, it is different. For males, they can have contraception for 3 months is practiced. For females, it is 3 to 6 months, which is practiced. In females, there's a risk of it is a teratogenic abortifacient drug. For males, it is basically it causes sperm abnormalities and oligospermia. That's why it has to be stopped. Next systemic drug which is used in psoriasis is retinoids. These are a family of naturally occurring vitamin A analogs. We have both natural and synthetic analogs of vitamin A which are used. Retinate also was used for therapy here, and then which was replaced by acitretin. Retinate, the problem with retinate was it was a highly lipophilic drug. It accumulated in the subcutaneous tissues and it did not show any effective action against psoriasis. So it was replaced with acitretin, which is less lipophilic. Safest drug which was used in safest systemic drug is acitretin. That is said to be the safest drug. The dose is 0.25 to 1 mg per kg per day. It is available as 10 mg and 25 mg capsules for treatment of psoriasis. So the uses is generalized psoriasis, pustular psoriasis, erythrodermic psoriasis, palmoplantar psoriasis, generalized pustular erythrodermic psoriasis in children. It is less toxic, so therefore for maintenance therapy you can use this. So this is less toxic, right? So for maintenance therapy for a long term you can use it. Mechanism of action is it probably involves interaction with retinoic acid receptors and regulation of gene transcription. They act by correcting the aberrant epidermal proliferation and differentiation. They also have an anti-inflammatory effect. Within the first 2 weeks of treatment, polymorphonuclear leukocytes are reduced in number with the horny layer and epidermis. Acid retin also modulates differentiation of the epidermis, resulting in decreased scaling erythema and plaque thickness. Before starting to exclude other contraindications, CBC, LFT, RFT needs to be done, glucose serum testing, and then pregnancy testing, spinal X-ray can also be done. During the treatment, also have to monitor for mucocutaneous side effects. LFT lipid profile has to be examined, RFT, and also X-ray of the spine pregnancy testing have to be done. Acetatin 10 to 25 mg capsules are available for once daily intake. Initial doses, you start the patient on 25 to 30 mg. If there is no improvement, then you escalate it to 50 mg per day. Then you, after the response is seen for after 12 to 16 weeks, you again reduce it to 25 mg per day. Gradually, it is seen in 3 to 6 months time. With methotrexate, it took 12 weeks, whereas here it is taking 6 months. There's an entity called as retinoid esters, which is recently introduced, which is a newer formulation which is used here, and that has reduced hyperlipidemia and reduced toxicity. Oral paxuretin, tazuratin also is available. Interactions is retinoids with tetracyclines you can't give because it will cause pseudotumor cerebri. Retinoids with alcohol you can't give because it is increasing hepatotoxicity. And vitamin A supplementation you can't give because of risk of hypervitaminosis A. Contraindications of acetatin are severe liver dysfunction, kidney dysfunction, pregnancy, lactation, childbearing potential, hyperlipidemia, alcohol intake, unreliable patient you can't give. Cyclosporine is the next drug for treatment of psoriasis. It's a cyclic indica peptide derived from the fungus Tolypocladium inflatum gums. It was first used in 1979. Mechanism of action is it will inhibit the T cells, so therefore it's anti-inflammatory action again it has got. It also inhibits the release of interleukin 1 and 2. Immunosuppression of the intraepidermal cytotoxic T cell response is again an mechanism. Orally it's active, highly lipophilic. Cyclosporine is called as crisis management drug because we don't use it casually in psoriasis. Only when it's needed we use it for its rapid onset of action. In erythrodermic psoriasis, generalized pustular psoriasis, palmoplantar, psoriatic arthritis, nail dystrophy, scalp psoriasis, and psoriatic arthropathy, we use this drug, which is cyclosporine, a crisis management drug. For short course, for 4 to 12 weeks, we use this. It's used in patients who need to suddenly terminate other therapies. We use this as a crisis management drug, again used as rotational therapy also. Nasal investigations has to be done, especially blood pressure monitoring, and RFT is important while giving the patient cyclosporine. The dose is 3 to 5 mg per kg per day. You can start with 0.5 to 1 mg per kg per day at fortnightly intervals. You can start the patient on 3 mg per kg per day. Then every 15 days, you can increase it by 0.5 mg per kg per day. Maximum dose is 5 mg per kg per day. Contraindications is renal disease, uncontrolled hypertension, malignancy, epilepsy, acute infection, immunodeficiency, other nephrotoxicity, gout, liver disease, pregnancy. Monitoring, you have to monitor for serum creatinine levels because it is a nephrotoxic drug. Every 2 weeks, it has to be monitored for 6 weeks. And also diastolic blood pressure needs to be monitored. If it is more than 90, then dose reduction needs to be done. Side effects of cyclosporine includes it can cause SCC, lymphoma, gum hyperplasia, hypertrichosis, structural functional abnormalities in the kidney, hyperkalemia. The drug-induced hypertension by cyclosporine is treated by nifedipine. This is a calcium channel blocker. Hydroxyurea, it's an antimetabolite which is used in psoriasis. Mechanism of action is inhibiting ribonucleoside diphosphate reductase, inhibits DNA synthesis. It is an alternative to methotrexate, less toxic. 500 mg BD is available. Side effects is myelosuppression, anemia, pancytopenia. Razoxis is another drug which is an antimitotic drug used in erythrodermic pustular and psoriatic arthritis. It's not hepatotoxic. Side effects include neutropenia, acute myeloid lymphoma, and B-cell lymphoma. Mycophenolate mofetil is another drug. It acts by inhibiting inosine monophosphate dehydrogenase. Inosine monophosphate won't be converted to xanthosine monophosphate. Active moiety is mycophenolic acid. Specific inhibitor of guanine synthesis, inhibition of DNA synthesis. Side effects is GI intolerance, vomiting, diarrhea. Urgency frequency, other side effects. Biological therapies available are these are targeted forms of therapy which target the specific etiological pathways in psoriasis. You have two main groups which have the drugs targeting cytokine TNF alpha, drugs targeting T cell and antigen presenting cells. TNF alpha inhibitors are etanercept, infliximab, adalimumab. APC inhibitors are efalizumab and alifacept. It is used in moderate to severe psoriasis, not responding to other systemic therapies, and psoriatic arthritis not responding to other therapies. Contraindication is severe viral, bacterial, fungal infection, active TB, and if the patient is at risk of developing sepsis, TNF alpha inhibitors, allergic reaction if the patient has, and hepatitis B, C, immunosuppression, pregnant, breastfeeding, malignancy, we don't use this. Precautions, all the history has to be taken, investigations need to be done, and pregnancy category, all of them are pregnancy category B except efalizumab, which is category C, and etanercept can be used in children. Etanercept is a recombinant human TNF alpha receptor protein fused with Fc portion of the IgG1 and binds to soluble membrane-bound TNF alpha. It prevents binding to cell surface receptors and inhibits pro-inflammatory effects of TNF alpha. 50 mg subcutaneously twice weekly for 12 weeks, then 50 mg weekly is given. Moderate to severe psoriasis, psoriatic arthritis are the uses. Side effects is injection site reaction, infections, and malignancy. Infliximab is another drug which can be used, which is another TNF alpha drug, human chimeric monoclonal IgG1 antibody with high affinity for TNF alpha. It destroys the TNF alpha producing cells. The dose is 50 mg per kg infusion, which is given over 2 hours at 0, 2, and 6 weeks. It's given, then every 6 to 8 weeks, once it can be given. It is used in severe psoriasis, moderate to severe psoriatic arthritis. Infusion reactions it can cause. The advantage is it has got rapid clinical response. Adalimumab is another drug which is the first fully human anti-TNF alpha monoclonal antibody. The dose firstly you give 80 mg subcutaneously you give first week, then you reduce it to 40 mg next week, then every 2 weeks once 40 mg subcutaneously you give. The uses are the same. Alifacept is another drug. It is a recombinant dimeric fusion protein. It binds to CD2 and memory T cells and inhibits the CD2 cell action. And also the doses, it is given as intravenous 7.5 mg once per week, or IM 15 mg once per week can be given. Efalizumab is a recombinant humanized monoclonal IgG1 antibody against CD11A. Inhibits the T cell activation, trafficking, and addition here. And 0.7 mg per kg subcutaneous dose is the dose here. Other biologicals are interleukin 12, 24 inhibitors and interleukin 17 inhibitors. And you have anakinra. Interleukin 12, 23 inhibitors are ustekinumab. 17 inhibitors are brodalumab, ixekizumab, secukinumab. Anakinra are the other drug, which is interleukin 1 receptor antagonist, which is anakinra. Corticosteroids are the other drugs which can be used in psoriasis, which have a very limited usage. It is used in persistent erythroderma, which is causing metabolic complications, in fulminant GPP, in disabling psoriatic arthropathy, in severe psoriasis in pregnancy or impetigo herpetiformis. You cannot use it otherwise. Systemic steroids inhibit mitotic index in psoriatic epidermis, used to treat acute exacerbations while changing to other drugs. Side effects of steroids is it causes HPA axis suppression, Cushing syndrome, growth retardation, glaucoma, glucose intolerance, weight gain. Other therapies available are gold therapy, which can be again used, but it is of now historical importance. Oral colchicine was used in a dose of 0.5 to 1 mg BD for 16 weeks. Zidovudin also can be used in HIV infected patients. Apremilast 30 mg or 20 mg BD was used. It's a phosphodiesterase 3 inhibitor that is used these days. It causes nausea and diarrhea. Tofacitinib is a JAK2 inhibitor, that JAK1 and JAK3 inhibitors that can be used. Ponesimod also is used as a sphingosine 1 phosphate receptor modulator.